Welcome to today's webinar, Automation and Emerging Methods with New Guidelines for HPV Self-Collection and Extended Genotyping. This webinar is a part of the 9th annual event in the Laboratory Automation Virtual Event Series. Today's educational seminar is presented by LabRoots and sponsored by BD. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to first participate by communicating with other attendees using our live chat feature during the presentation. You can find the live chat located at the left of your screen. If you have trouble hearing or seeing the presentation, click on the Help Desk button located at the top of your screen within the navigation bar or from the lobby within the event. Today, we're excited to explore two new recommendations from the Enduring Consensus Cervical Cancer Screening Management and Guidelines Committee of the American Society for Colposcopy and Cervical Pathology, ASCCP. These two new recommendations provide guidance on how to manage HPV results obtained with self-collected vaginal specimens and how to manage HPV extended genotyping results. We're also going to share how automation can help your lab run the BD Onclarity HPV Assay. First, though, please allow me to introduce today's speakers. I am your moderator, Molly Broache. I serve as Associate Director, Payer Relations and Market Access for BD Diagnostic Solutions, and I am also a licensed women's health nurse practitioner. I am a member of ACOG, NPWH, ASCCP, and I serve as a junior member on the AMP Economic Affairs Committee and as a member on the NPWH Research and Quality Improvement Committee. I'm currently completing my Doctor of Nursing Practice degree at the University of Maryland, Baltimore, with an anticipated finish date of May of this year. I'm passionate about expanding access to women's healthcare with an emphasis on increasing patient access to innovative diagnostics for women's health screening. It gives me great pleasure to introduce today's keynote speaker, Ibtihaj Awadelkariem. Ibtihaj is an AAB board-registered medical laboratory scientist with certifications in microbiology and hematology. She has over 20 years' experience in hospital, clinical, and reference laboratory settings. Following roles at Reston Hospital Center in Reston, Virginia, and Inova Hospital in Leesburg, Virginia, Ibtihaj founded and now runs Clinical Diagnostic Laboratories, CDL, in Ashburn, Virginia. Ibtihaj has exceptional experience at the cutting edge of laboratory operations, including the running of the BD Onclarity HPV Assay, the first and only FDA-approved HPV assay with extended genotyping and self-collection in a healthcare setting. She possesses extensive knowledge of extended genotyping and the associated ASCCP guidelines. Finally, Brittany Nesbitt serves as the Senior Manager, Market Access and Payment Policy at BD Diagnostic Solutions, and she is joining us today to help us understand the payer landscape as it relates to HPV screening with extended genotyping. Brittany holds a degree in health science with a concentration in healthcare administration from Florida Gulf Coast University. With 15 years of experience, she previously served as a regional revenue cycle manager for ambulatory surgery centers. She also has 5 years of experience in the medical device industry. In 2022, Brittany joined BD, where she focuses on the full diagnostic platform, leveraging her expertise to drive innovation and efficiency in healthcare diagnostics. This presentation is on behalf of BD. Any discussion regarding BD products during the presentation today is limited to information that is consistent with the FDA approvals or clearances for these products. Please consult BD product labels and inserts for any indications, contraindications, hazards, warning, cautions, and instructions for use. The opinions and clinical experience presented herein are for information purposes only. Our guest speaker has been compensated by BD to give this presentation. Today, our learning objectives are 1, understanding new ASCCP extended genotyping and self-collection recommendations, 2, an explanation of extended genotyping, and 3, a review of a new CPT code for HPV testing. The BD Onclarity HPV Assay is an FDA-approved HPV assay that detects DNA from 14 high-risk human papillomavirus, or HPV, types that are associated with cervical cancer. The test provides extended genotyping results for HPV. It individually identifies HPV genotypes 16, 18, 31, 45, 51, and 52, while reporting the other high-risk HPV types in groups 3358, 353968, and 565966. ASCCP has issued new recommendations on how to manage HPV results obtained with self-collected vaginal specimens and how to manage HPV extended genotyping results. The new recommendations represent a significant step forward in the management of HPV results. In addition, a new CPT code has been issued to identify HPV tests, including BD Onclarity, that test for 1 to 3 pooled high-risk HPV results and up to 6 individual high-risk HPV results with a single procedure. BD Onclarity is the only test that combines extended genotyping and FDA approval for self-collection in a healthcare setting. This webinar will cover extended genotyping, its importance in providing better patient management, and how to code correctly to capture the new reimbursement rate associated with HPV tests that incorporate extended genotyping. At BD, we're committed to eliminating cervical cancer through screening. We approach this in 4 pillars. Number 1, being at the forefront of clinical advances with BD solutions to provide flexibility to address the evolving needs of clinicians and labs. 2, empowering women to self-collect in private, providing comparable performance to clinician-collected samples. 3, bringing efficiency to cervical cancer screening. And 4, enabling enhanced risk stratification with extended genotyping. It now gives me great pleasure to hand it over to our keynote speaker, Ibtihaj Awadelkariem.
Thank you, Molly. I'm delighted to have the opportunity to speak with you all today about new guidance on HPV testing. Why is this important to my providers and how we run the BD Onclarity HPV Assay. With the option of self-collection in my lab, Clinical Diagnostic Laboratories, which is located in Ashburn, Virginia, and we added the BD Viber Ltd in our lab for the HPV testing. As well, we're accepting walk-in patient to test for HPV. To level set, the purpose of cervical cancer screening is to detect pre-cancer before it can develop into cancer. The best way to do this is precisely stratify risk and manage based on risk. Simply put, extended genotyping offers a more refined level of risk stratification for a more precise care plan compared to partial or limited genotyping. So, at a high level, let's talk about how. Limited genotyping provides individual results for HPV type 16 and 18, and a large pooled result for the other 12 high-risk HPV genotypes. The HPV types in this large pooled result vary in their immediate risk for developing SIN3+, as well as cancer attribution. On the next slide, I will review this. Including these 12 other high-risk types as a pooled result can falsely elevate or minimize a patient risk for cervical cancer. The ASCCP latest guidelines recommended a more precise triage for this high-risk pool, indicating the lack of clarity of large pooled result from a risk stratification perspective and subsequent impact on the clinical care. This compared to BD Onclarity within 6 individual call out 16, 18, 31, 45, 51, and 52, and the 3 small pooled result. No other FDA-approved assay on the market provide the level of detail of the BD Onclarity for comprehensive HPV results and precise risk stratification for more precisely managed based on risk. Over the next few minutes, I will go into detail about how the latest ASCCP guidelines recommended a more precise approach for risk stratification to enhance clinical management. This is all about personalized patient management, allowing providers to focus their attention and resources on the highest risk patient and decrease unnecessary procedure in lower risk individuals. First, since 16 and 18 confer the highest risk for cervical cancer, these are placed in the highest risk category. A recommended management is colposcopy, regardless of cytology status and co-testing. Drawing your attention to the very bottom of this chart, you will see the 56, 59, 66 confers the lowest risk of the highest risk HPV types. So no triage for additional risk. Stratification is needed, and this patient can be counseled to safely follow up within 1 year. Every other genotype is considered moderate risk based on the dataset that were used to inform these guidelines. Thus, a triage recommended to further risk stratify and determine next step in management. Triage can either be cytology or Doll stain. These guidelines aim to integrate new technologies and approaches that improve cancer prevention for higher risk individuals and decrease unnecessary procedure in lower risk individuals. The HPV vaccine is working and it's causing shift in high-risk HPV distribution. While genotype distribution can differ among us age group and vaccination status, current approaches have remained focused on only the 2 historically most high-risk HPV, 16 and 18. However, screening with BD Onclarity HPV Assay of more than 25,000 women for over a year revealed that prevalence of vaccine and cross-protected HPV, i.e. HPV 16, 18, has decreased. Prevalence of the other 12 non-vaccine types of high-risk HPV has increased but particularly HPV 56, 59, 66, accounting for nearly a quarter of HPV positives. Managing screening strategies based on real-world data has the potential to positively impact many patients, but also allow providers to focus their attention and resources on patients at the highest risk for cervical cancer and safely follow up with the lower risk individual on 1 year. The BD Onclarity HPV Assay is also available with the option of self-collection. In a healthcare setting, and the ASCCP has recently released recommendation for HPV result obtained with the self-collected vaginal specimen. Per the FDA, the intended use is as follows. Self-collected vaginal specimen obtained in a healthcare setting can be tested as alternative specimen type when cervical sampling is either contraindicated or cervical specimen otherwise cannot be obtained. This can include patients with disabilities who are unable to get into the position for a pelvic exam, patients for whom inserting speculum is contraindicated due to severe pain, or patients who are gender fluid or with a history of sexual trauma, where a pelvic exam causes distress, or a patient who are simply just uncomfortable with the pelvic exam. Offering self-collection as an option for a cervical cancer screening improves health equity and improves patient to engage in a shared decision making with their providers, which helps build trust and, importantly, screening participation. A healthcare setting is broadly defined as any place where trained healthcare worker can process the self-collection samples, including traditional clinic, mobile units, health fairs, outpatient labs, and even potentially home health care. I thought it would be interesting to share the workflows associated with the self-collection and how I accommodate this test in my lab. The biggest difference in that the self-collection swab is shipped to us in a dry plastic tube. We then simply break off the swab into HPV self-collection diluent tube that is then loaded into the instrument. To run the BD Onclarity HPV assay, I use BD Viber, as I mentioned before. BD Viber LTZ system provide me with fully automated molecular testing. This gives me the ability to deliver more precise insight to my provider, allowing for the extended genotyping that I have just touched on. From efficiency perspective, the system is compact, integrated, and self-contained tabletop system that also has room temperature reagent storage and allow for sample to result within with a single system. BD Viber LT is suitable for low to mid volume specimen, which you can run series of HPV tests within 4.5 hours or 120 tests in 9.5 hours. For application with the highest volume demand, the BD core system represents the next step for laboratory efficiency. Delivering efficiency, flexibility, and performance to meet your laboratories involving molecular diagnostic needs, the BD core system uses multiplex PCR assay design and requires less than 1 hour of daily hands on time for the full BD core system workflow and 2 interactions. Highlighting efficiency, the system offers fully integrated automation from specimen to result. Minimal interaction is required to maintain a high level of system throughput. From performance standpoint, the system is modular and scalable to deliver needed throughput and overall system output. Thank you.
Thank you, Ibtihaj, for delivering such insightful information to our listeners. I am now thrilled to speak with Brittany from BD's Market Access team about the new CPT code applicable to the BD Onclarity test.
Hi, Molly. Thank you.
Hi, Brittany. I recently heard that there are changes in how HPV testing is coded. Can you explain what the changes are?
Of course, happy to explain. So, effective January 1, BD has a new CPT code. It is going to be applicable to the BD Onclarity HPV assay, as well as other HPV assays that fit the code descriptor. 87626 is the new code. This code describes an assay that detects and differentiates in a single procedure 1 to 3 pooled high-risk HPV results up to 6 individual high-risk HPV genotyping results that are known to be the leading causes of cervical cancer, and this is the appropriate code to bill effective January 1, 2025, dates of service.
Great to hear that there is a new code that more appropriately describes the BD Onclarity test. Are there any changes to reimbursement for 87626 versus the previous CPT code that was billed for the test?
Yes, the new rate published by the Centers for Medicare and Medicaid is $70.20. Each state Medicaid will post their own rates. Commercial insurances work differently. Each provider and lab privately negotiates their own rates, so they'll need to contact their commercial insurance companies that they contract with to confirm those new rates.
Thank you. Are there coverage or reimbursement concerns with this change?
So we anticipate that coverage will remain the same. Screening for HPV is widely covered service as long as the HPV is done in the correct age group per clinical guidance. When it comes to reimbursement, I would recommend some tips to ensure a smoothing billing process.
Would you mind sharing those?
Of course, you want to please make sure that 87626 is in your billing software and check your fee schedules for updates. Make sure that your clearinghouse has the new code in their system and that you reach out to payers if you cannot find the code on their website. We recommend that you check the code through a benefit verification site to ensure the code's listed as active for each of these payers. These are just some of the best practices for all billers when any new code is being introduced to the clinical lab fee schedule.
Thanks so much for this information. And thanks again to Ibtihaj and Brittany. It's been fascinating to delve into these new guidelines and how they can ultimately benefit patients. We will now start the Q&A portion of the webinar. Alyssa Davis, a physician assistant and medical science liaison for the BD Diagnostic Systems Women's Health and Cancer portfolio in the US, will also be joining in our Q&A session. Alyssa acts as a scientific peer and resource both internally amongst colleagues and externally within the broader medical and healthcare community. If you have a question you'd like to ask, please do so now. Just submit a question in the Ask a Question box located at the bottom of your screen. Let's get started. All right, so the first question I'm seeing I am going to give to Alyssa. Alyssa, how prevalent is HPV self-collection?
Thank you, Molly, and thanks for the introduction. So self-collection within the healthcare setting specifically is really a new concept in the US. So it's really just starting to gain traction. And this is really based on the new enduring guidelines from ASCCP, which I know we had mentioned within the webinar. So if we look to other countries as an example, since this is something new for us, other countries throughout the world have had this option for a longer period of time. And the data from those countries really suggests that self-collection is going to increase over time and continue to be a great option for providers and patients. So we expect with this kind of new support of the guidelines and new technologies coming into play, that things will just continue to pick up over time. So right now, it's really just in the early beginning phases, but there's a lot of work to do.
Great, thanks, Alyssa. And the next question I have is for Ibtihaj. Ibtihaj, can you share some more about the workflow when running BD Onclarity with self-collection in your lab?
Sure, Molly. After we get the specimen in the lab, after the swab is being collected, and there's multiple ways for the specimen to be collected in the health care facility, or patient can come to the lab. So when we get the specimen, which is delivered in a plastic tube, we take the specimen and put it in the diluent. After that, we pre-warm the specimen, which it take about 1 hour, and it is stable after that for 7 days. That's the good part also. So after you pre-warm the specimen, you can stable it for 7 days, room temperature. And after that, we prepare the instrument by loading all the reagent needed. And after that, just start and run. An estimated time to complete 32 samples is about 3.5 hours.
Excellent. Thanks so much for explaining that. All right. So the next one that came in, this one is for Alyssa as well. So within the presentation, the cervical cancer management guidelines were mentioned. Can you touch a little bit on what the screening guidelines for cervical cancer tell us about extended genotyping?
Yes, great. Yes, great question. Because before we even get to the management guidelines, we have to kind of know what to do to get to that situation. So we have in the US, from a screening perspective for cervical cancer testing, we have the American Cancer Society and we have the United States Preventative Services Task Force, or USPSTF. Both of those guidelines have, unfortunately, right now, a little bit of differences in the ages and the screening methodologies. But what we've seen within the past few months, excitingly, is that there is going to be a little bit more alignment within the two organizations. And so regardless of what age we have recommendations for starting screening or the methodology used, we've seen both of these overseeing organizations in support of HPV primary screening as well as HPV self-collection. And so both organizations have advocated for HPV self-collection as a great tool to help increase our access. And so American Cancer Society has been behind that for a little longer. USPSTF earlier this year had opened up their draft recommendations for their updates, and self-collection was included as a screening option. Now, those were the draft recommendations. We are waiting for the final recommendations to be published, but I expect for HPV self-collection to still be included in that. So it's really exciting. Again, I'm a provider as well, so having those guidelines supporting this really innovative and great technology is just fantastic. And so we have really a little bit more uniform recommendations across the board with ACS, USPSTF, which will then get us to ASCCP for the actual management.
Apologies, I muted myself. I was just saying thank you so much, Alyssa, for explaining that, and we'll be anxiously awaiting the USPSTF guidelines. And we have one other question for you that came in. What are some of the common misconceptions about self-collected HPV tests? I know there's lots of pros and cons being discussed about them.
Yes, thank you, Molly. And I was hoping that there wasn't a technical issue on my end. So
Yeah.
Yeah, so there are a lot of in this world, day and age, we know we have a lot of misconceptions that kind of float around within the health space in particular. And one of the biggest things that we see from a misconception perspective is that self-collection isn't as accurate as clinician collected samples. However, we know based on studies that this is just not true. There is a lot of supportive evidence behind the fact that self-collection for HPV is just as reliable as a clinician collected specimen for HPV testing, especially when used correctly. We also know from large scale modeling that cervical cancer in the US will decline more rapidly when we focus on increasing our screening rates than just focusing on increasing vaccination alone. And vaccination outreach has been a really big focus globally. The World Health Organization has been a huge advocate for that, but we're not going to achieve cervical cancer elimination with vaccination alone. We really need to kind of double up the efforts and add in improved screening access. And then I would say the other big misconception is that people really need to learn how to properly collect the HPV sample. It's a really simple process. Like patients, we know there's been self-collection options for other tests on the market for quite a while, FDA-approved solutions. And so patients with a vagina can do this. We don't need to have any sort of special training. It really comes down to just properly educating and empowering our patients to be able to do this specimen collection. The swab itself really looks very similar to the COVID swabs. And so if we take a lesson learned from that time, at this point, 5 years ago, it's really pretty simple to do. The swab for this is actually smaller and less intrusive than a tampon or a speculum exam would be. And so it's really less intimidating and really a lot easier for a lot of patients to manage.
Excellent. Thanks so much. This next question is going to go to Brittany. Brittany, will all HPV tests now be billed with the new CPT code that you mentioned in the presentation, the 87626 code?
So thanks, Molly. Actually, no, that is reserved for tests that have extended genotyping in the original result. So when the test is ran and you either get a positive or a negative with our test and a couple of others on the market, you'll automatically understand or know if there is genotyping. If you're using a test that requires you to rerun the sample to get the extended genotyping, then you would go with the 2024 coding guidelines of 87624 and 87625 added when it is positive.
All right, awesome. Thank you so much for that clarification. All right, next one is again going to Alyssa. This question says, what happens if a patient from an underserved community needs cytology following an abnormal self-collected HPV test? How are we ensuring that they come back in?
I would say this is probably one of the top questions that we get, right? We have this this new tool, this new innovation, and we want to get it out to the masses. But if we don't have a process set in place to ensure follow-up for treatment or for triage testing, then we're not necessarily doing any good. And so this is really where implementation science comes into play. When we kind of step back and we say, with our industry hats on, right? We can't necessarily provide a step-by-step process that practices and clinics can use to get this out into the communities and ensure not just testing, but accurate follow-through. Because in the US, all of these underserved demographics that we're really targeting with HPV self-collection present very unique challenges that are going to differ from population to population. And so we don't have really a homogeneous solution that's going to ensure that these patients are able to get in for follow-up, regardless of what that follow-up is. And so that's really where I would say there's a little bit of a call to action for those within the space that have establish themselves as the innovators and the kind of leaders in this field to work within their communities on implementation science to figure out how this works in these underserved populations. How can we make this happen in an FQHC? How can we make this work within unhoused populations and immigrant populations? We have such vast differences for underserved rural communities as well as underserved urban communities. And so the challenges that are there that prevent them from getting in for screening are also not going to be completely eliminated with self-collection. We have to figure out how we can get them in for continued care. So I don't have a straight answer for you, but again, a call to action for all of those innovators within this space to really work on implementation science so that we can ensure that we're not just getting tests out there, but we're making sure that there's accurate follow through too.
Excellent. And I mean, this is sort of a follow-up to that. This question asked, with more providers adopting self-collection, how do we ensure patients are also going on or going to the office for their annual preventative care visits? Because I guess that's another aspect of this. If somebody's, self-collecting, we want to make sure they're also getting those other things that come along with a annual or well woman visit, blood pressure checks and labs and things like that.
Yes. And I'm not sure. I would say that as a women's healthcare provider, which was what my background is, and Molly, I know you have a similar background with that as well. I am all for embracing some of these new technologies. And I think it gives us as healthcare providers a chance to kind of reinvent what the annual preventative visit may look like. I know traditionally it was always once a year you come in and we kind of have this checklist that we work through. And some of the non-negotiables like that cervical cancer screening test. And so having this kind of new way to screen patients and I would say, advancement of telehealth over the years, especially again, kind of sparked with COVID, we have a little bit of a chance to kind of revamp what we're doing from this preventative healthcare space. And so for patients who aren't comfortable coming in and having that speculum exam for cervical cancer screening, if we let them know that self-collection is an option, that alone may prompt more patients to come in when they know that pop your feet up into the stirrups and scooch towards me isn't going to be necessary for their visit, right? We may be able to have longer time to counsel patients on their menses and their contraceptive options, family planning, and maybe we can have patients feel comfortable with just a breast exam or just a vulvar skin check. So this is really not trying to take away from the patients who are already coming in and who maybe are okay with the speculum exam. We're just trying to capture more of those patients who have been avoiding it or haven't been able to come in for a number of reasons. And I would also say that hopefully this as a tool, hopefully empowers patients to feel safer coming into these spaces as well. So there's a lot of work to do with just kind of educating our patients appropriately, and educating them that as well that an annual preventative exam is not synonymous with cervical cancer screening, and that the two can go together, but they don't need to happen at every single visit together as well. So a lot of patient education, I would say, is going to be needed.
Excellent. I love that. Yeah, it seems like a whole sort of reframing of what an annual visit is, and not scaring people that it's always a PAP.
Yes.
So the final question that came through, and I'll open this up to Alyssa, but Ibtihaj, if you want to comment as well too. I know coming from the lab standpoint, there's probably some education going on, but this question was, what is being done to help providers become more knowledgeable about extended genotyping? So would appreciate your comments, Alyssa, and maybe yours as well, Ibtihaj.
Sure. And I can chime in on this first, because I kind of alluded to this before. And I know it was touched on as well within the webinar, but we had that formal release earlier this year of the ASCCP Enduring Guidelines, which are in support of using HPV extended genotyping, specifically the BD Onclarity assay, as a really excellent option to support decision-making for providers. So the publication in itself is of particular help to providers, because they can know that they're able to better triage their patients based on these test results, whether it be simply follow-up or colposcopy or cytology. We've seen a lot of evidence from the BD Onclarity clinical trials that we've had that are in support of extended genotyping as a better triage option. And so to have the support of the ASCCP Enduring Guidelines as well behind us is just really, it's really great. And I think that it's really validating that this assay itself is truly based in science, and kind of has shifted the way that we need to help improve screening. And so ASCCP continues to be a really great resource. Their publication is very hefty. And so it's a long read, but it's a great kind of why we got to this point. And I would say also, reassuringly enough, ASCCP update our trusty app that we rely so heavily on. The app updates will be coming in the near future. And so that will be I think more in front of providers throughout their day-to-day when they go to plug in results, and you'll see, oh, what is extended genotyping? And so that should hopefully drive more folks to continue to inquire about extended genotyping and learn about it.
Excellent. Thanks, Alyssa. All right. So that is all the questions I am seeing. So thanks again, Brittany and Ibtihaj and Alyssa, for your time today and your important work. Before we go, I'd also like to thank the audience for joining us today and for your interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed via the contact information you provided at the time of registration. So feel free to ask questions if you didn't get to them already. This webcast can be viewed on demand for 1 year until March 19th, 2026. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.